We'll get started. Good afternoon, everyone, and thank you for joining Relation Insurance Services quarterly compliance webinar, where today we'll be looking towards 2024 and discussing some key regulatory changes that are impacting employee benefits. My name is Matt LoPorto, and I am VP of Compliance at Relation Insurance Services. And I just want to take this opportunity to thank everyone for joining our webinar today. And if you were with us last quarter, where we discussed the compliance requirements around COBRA continuation, welcome back. And if this is your first time joining our compliance webinars, welcome. I know I mentioned this during our last call, but it's something I would like to reiterate today. And that's one of our main goals on having these compliance webinars is to elevate your relationship with compliance. And the way we strengthen any relationship, and our relationship with compliance is no different, right? The way we strengthen those relationships is through communication and an open dialogue. And that's really what we're doing here today, right? We're having a conversation about compliance, right? We're taking compliance off of that back burner, and we're being proactive in our approach as we work towards creating that compliance for our employee benefits programs as an area of strength. So with that being said, I encourage everyone on the call today or listening to the recording, I encourage you, if there's any topics that you hear today that you would like more information on, or to take a deeper dive on, or just sit down with the relation team to discuss and review your current compliance policies and procedures, to possibly see, is there a way to, do something maybe a little more effectively, a little more efficiently, please reach out to your relation account teams, let them know that you'd like to sit down, with me to have a more, in-depth, continuing conversation on compliance. We'll say it again at the end, but, we're here to help. So, please, view this webinar today as a starting point for us to continue that, that conversation and that building up of that relationship we all have with our compliance programs. All right, so before we go into our topics today, I do want to mention we will have time at the end of the presentation for questions and answers. So if you do have questions during today's presentation, we do have a chat box on the side of the screen labeled Ask Questions Here. So if you can please type your questions there, we will get to them at the end of the call today. And if there are any questions that I need to take away, do a little additional research on, what I'll do is when we send out the recording, the PowerPoint slides, there's some supporting documentation that I'll reference later. So we'll send all of that out after the call. What I'll do is, if there is any questions that I need to do additional research on, in that email, I'll restate the question and provide a response there so everyone is aware of that answer. All right. So the first topic we're going to discuss today is actually one way that we at Relation, our compliance team, and myself included, this is one way how we strengthen our own relationship with compliance, and that's through our partnership with the Council of Insurance Agents and Brokers, the CIAB, specifically with our work in the Legal Counsel Working Group. And the CIAB's Legal Counsel Working Group, one of their main responsibilities is to advocate on its members' behalf on regulatory issues impacting employee benefits and group health plans at both the federal and state level. So what we'll do on this slide is we're going to review some of the regulatory items that CIAB was working on in 2023, and what they'll be continuing to monitor, to advocate for or against as we move into 2024. So first, we'll take a look at on the federal side, and the top plate issue is pharmacy benefit managers. And there's been a number of proposed regulations impacting PBMs, and they all have to do with increased transparency and limiting cost. And with that limiting cost, that's including putting that cap on the price of insulin, right? It's all kind of included in there in these PBM proposed bills. And actually, one of the proposed bills that impacts PBMs actually just passed the House. So it is really good, I think, to see some positive momentum happening with these bills as we enter 2024. The CIAB has stated their approval of they're proponents of these proposed bills that would increase transparency, limit cost for PBMs. These bills do have bipartisan support, which is great. So I do think it's more a matter of when these will pass rather than if they will pass. However, on the other side of that, right, these PBMs, they have lobbyists as well. So that's kind of will be where where the battle is just between the differing lobbyists there down in DC. But we're going to continue to monitor this with our work with the CAB. We'll keep everyone aware, of these items when they pass, when there's more to share. But it is something that, on the federal side, it's definitely, moving, and with that bipartisan support, I think sooner rather than later, we'll be getting some more news on PBM's transparency and cost. The other item on the federal level is mental health parity. And there is actually a new proposed regulation that would actually add to the reporting requirements that were implemented with the Consolidated Appropriations Act. And I have an asterisk here on mental health parity because we're going to talk about that a little later on in our presentation today, specifically with those reporting requirements that were implemented with the passing of the CAA back in 2022. However, the CIAB is opposing this proposed legislation. And there's really two reasons around that. The first is we just have new reporting requirements with the Consolidated Appropriations Act, right? Is there really, a need for, additional reporting requirements on top of something that is, still so relatively new? And then the other reason the CIAB is opposed to this legislation is the actual wording of the bill makes compliance really difficult. The wording in the bill tends to be more on the vague side, which from a compliance person, right? It's like, how do we meet these requirements? What do we need to do, right? We don't like surprises, and the vagueness that's in the bill, using terms such as, taking reasonable action when there's a material difference between medical, surgical versus mental health and substance use benefits. Well, what does material difference mean? So they're not defined, in the bill, as well as, having meaningful benefits. Well, what's a meaningful benefit? So those are the two main reasons here that CAB has opposed this proposed legislation with the added requirements there on reporting for mental health parity. But again, it's something we're tracking. And actually, the next Legal Counsel Working Group conference is taking place in February. And it's actually CIAB's Day on the Hill. So we'll be sitting down, with members of the Senate to hear from them, to hear what their, top plate issues are, and they'll hear from us too. We'll have an opportunity, to speak about, what our views are on, PBMs, the mental health parity proposed regulations, some of the other, top plate issues that are impacting, employee benefits and group health plans. I went last year, and it was a great experience. So I'm really looking forward to taking part in, CIAB's Day on the Hill, and I will definitely be reporting back to that, probably in our next quarterly compliance call. So definitely more to come there. And then on the state level, a few issues that I'd like to discuss. On the state side, we're seeing multiple states, and a few states have already passed this. Other states it's still proposed regulations where it's increasing the enforcement of the Consolidated Appropriations Act, the No Surprises Act. What states are doing, they're taking the language that was passed at the federal level and rewriting it so that it's at the state level now. And the reason for this is primarily geared towards hospitals and hospital price transparency to make sure that that is, being completed in accordance with the requirements. And the feeling is if this is at the state level, then the state's own insurance department has jurisdiction over that law, and they're able to enforce it, in their minds better than the enforcement can be done at the federal level. So it's really just taking it and moving it down and who's enforcing these requirements. So it's definitely something we're keeping an eye on because I do think it, benefits, members. Obviously, the more transparency, in the healthcare space, particularly with the hospitals, is better. The next issue is dental loss ratios. And I think at face value, right, I think dental loss ratios, it's easy to see why you would think that this is an issue between dentists and dental providers and insurance carriers. But if you start peeling it back, it really has a greater impact, and it does impact employers and members. And the reason I have Massachusetts here as an example For a number of years, the Massachusetts Dental Association, maybe 4 or 5 years, they were working on getting a dental loss ratio bill passed through the Massachusetts legislature. And it never passed, right? And if you think about it, at the federal side, the ACA implemented medical loss ratio, but when they did that through the ACA, right, dental is an accepted benefit, right? Dental did not need to meet those medical loss ratios because dental is different than medical. And the Massachusetts legislature agreed with that and never passed those bills. However, the Dental Association in Massachusetts was able to work to get the dental loss ratio bill on the Massachusetts ballot as a ballot initiative, and it got voted in. So effective January 1st of 23, Massachusetts now has a dental loss ratio. I think it's like 85%, maybe 88.5%, whatever that percentage is. It was implemented starting 1/1/23. Well, since January in Massachusetts, 5 carriers have pulled out of market. They are no longer offering their plans in Massachusetts because they're just unable to meet that loss ratio threshold. So who does that really impact? It's loss of options for the employers, particularly smaller employers, and it's impacting negatively impacting your members. So just something I want everyone to be aware of here with dental loss ratio, because the ramifications, it definitely trickles down to the individual members. And then the last item here on the state overview is pharmacy benefit managers. Very similar to what's being looked at the federal side, right? Increased transparency, limiting cost. So just different states have bills proposed there that we are monitoring. The CAB is monitoring as well. Interesting of note, the NAIC, the National Association of Insurance Commissioners, has just published a white paper on what they feel, the correct regulations and reporting requirements and so forth should be at the state level for PBM. So that'll be interesting to see, what comes out of that white paper, maybe even with more states looking to implement some requirements there. All right. So that is our recap and looking forward here for CIAB for 2024. So next, we will talk about the ACA employer mandate, affordability, and then a change in filing requirements. So we are aware that under the ACA, right, we need health coverage has to be affordable and it needs to provide minimum value. And of course, the ACA, the employer mandate, it's going to be applicable to large employers, the ALEs, right, 50 full-time equivalent employees. And I'd like to spend the next couple slides discussing affordability and the affordability percentage. So here, affordability, it's going to look at what the employee's contribution is, and it's only going to look at your lowest plan cost option, right? If you're offering multiple plans, not every plan needs to meet the affordability percentage, just your lowest plan option has to, right? So that's good to know if you're offering multiple plans. One of them needs to meet this affordability percentage. It is for self-only coverage. And here I have in that if the family glitch was fixed, and that goes back to the 2023 plan year. And what that means is that coverage is affordable for family members if the portion of the annual premium for the employees pays for the entire family, right? Does not exceed the affordability percentage. Prior to 23, if self-only coverage was deemed affordable, then all coverage for employee and spouse, employee plus family, all of it was deemed affordable. But with the family glitch fix, it's now looking at affordability not only at the self-only coverage, but affordability at the family level as well. The good thing though for everyone on the call here, the ACA pay or play penalties only impacts the self-only coverage. It's still only looking at self-only. Family coverage is just for the premium tax credits for employees. No impact on the testing that's required on the employer side. And the last bullet point here, right, that affordability percentage does vary from year to year. And in 2024, for the 2024 plan year, the affordability percentage is 8.39% of the employee's household income. And when we're looking at affordability, right, we don't necessarily know the employee's entire household income, So we have three safe harbors that we can utilize to determine if a plan is affordable, right? And the safe harbors are the Form W-2, the rate of pay, and federal poverty line. So for the W-2 safe harbor, we're looking at the employee's wage as reported in box 1 of the W-2, and we're multiplying it this year by 8.39%. And there you can see it's going to be affordable if that cost is equal to or lower than this calculation. Well, you may look online at these different safe harbors. You might see that this W-2 is good when there's consistent annual income. However, we would, this is hard to plan for, right? Because what is consistent with people's, changes and leaves, even is anything in our worlds, ever really consistent when it comes to, employee benefits. So this one, I think, tends to be very difficult to plan for. So just kind of throwing that out there. The next safe harbor is the rate of pay. And here we have different calculations for hourly employees and salaried employees. Here for hourly employees, you're taking their hourly wage and you can multiply it by 130 hours, right? Which is the minimum threshold for in a month for full-time employment. Regardless, even if they work, more hours per month, you can, utilize that 130 for this calculation. And then you have the salaried down there. And again, the plan is going to be affordable if the cost to the employee per month is equal to or less than the final figure. And then we have the federal poverty line safe harbor. And here the federal poverty line is currently set at $14,580. And the IRS will publish a new federal poverty line for 2024, starting, I think that comes out in mid-January. However, for calendar year plans, you are able to utilize the current 14,580. There's a 6-month window where plans are allowed to use the federal poverty line looking back. So you can kind of see here, I did the math for us, but again, I wanted to clarify, it's for 2024 calendar year plans, right? If your plan, let's say, starts on July 1st, if that's the first day of your plan year, you're not going to be able to utilize the federal poverty line of 14,580. You'll have to utilize the poverty line that's coming out in mid-January. So again, just work with your relation account team. They'll be aware of the new number when it's established, and we can certainly work with everyone on that if the current line is not available based on when your plan year starts. For this safe harbor, I think it might be the easiest to calculate because you're not looking at individual salaries, right? You're dealing with one, a static number, but this is the most conservative approach. So, please take that in mind when you're working, with your account teams on determining affordability using these safe harbors. So next we have certain due dates, right? We have the 1095-C and the 1094-C forms. So for 1095-C, the due date to furnish to individuals for 2024 is March 1st. And I think that date is a little different for this year with 2024 being a leap year, right? I think we get the extra day in February. So that 60-day count is a little different, but for 2024, for 1095-Cs, the date is March 1st. And then the 1094-Cs to electronically file with the IRS is April 1st. So those are the due dates that are, coming close, right? We want to definitely start planning for those. And then, as I mentioned, when we started these slides on the ACA, there are new regulations that require electronic filing. So now, as long as you file 10 or more returns in aggregate in a calendar year, you have a requirement to file electronically. And I do think this is going to impact, if not everyone on this call, the vast majority. And you can kind of see here how they determine the aggregation of returns, right? You're counting W-2s, 1099s, 1094s, 1095s. Those are all added together to determine your aggregate number. And if you're hitting 10, or higher, you now have to file electronically, starting with the filings that are due in 2024. So just something to be aware of, a little change there in the filing instructions. Okay. Next, we have penalties. So for here, for the 1095 and 1094s, those C forms, if they're late or incorrect, the penalties there are $310 per employee. So if you're late with 1095Cs and then you're late with the 1094Cs, it's going to be $620 per employee. So we want to make sure, again, that we're staying on top of those due dates. And again, please work with your relation account teams on making sure that we're meeting those deadlines to stay in compliance. We want to avoid penalties for just being late. We'll stay on top of that. All right, the next set of penalties, we have the we have the A and B penalties. So for the A penalty, right, this is when a plan fails to offer group health coverage to at least 95% of full-time employees, right, and their children for any month during the year, when then one of those employees enrolls in exchange coverage and receives a premium tax credit. And so this penalty is viewed at the group level, and the penalty is determined. They take your full number of full-time, your FTEs, your full-time equivalent employees, and they minus 30. So whatever that number is, right? Full-time employees minus 30, they then multiply that by, for 2024 plan year, they're going to multiply it by $2,970. And that's the penalty for A, right? If you're not offering coverage to 95%. So you can see how that gets to be a rather large number fairly quickly. The B penalty, which is at the individual level, if you fail to offer affordable or minimum value coverage to a full-time employee who then again enrolls in exchange coverage and receives a premium tax credit, and that penalty for the 2024 plan year is set at $4,460 per employee. Interesting to note, though, that this B penalty will never be larger than what your A penalty would have been. And the one thing that I will say about the A and B penalties, and hopefully no one on this call will ever get a letter from the IRS about these penalties, but if you do, please reach out to us here. We had 2 groups this past year that received letters and they were prior years, right? The IRS, you can imagine, is fairly behind on these reports. I think the ones we looked at were back from like 2021, and I think they're back from like 2021 actually. So we were able to work with the client, and we were actually able to revise the forms, right? Internally, we looked at them. We were able to see that maybe there was a different way of filling out these forms, classifying the employees, maybe as seasonal rather than full-time. And we were able to respond, draft a comment letter back to the IRS. We helped the employers, we helped our clients with that. And those substantial penalties were significantly reduced to a place where, the clients that we were working with were happy with the end result. So again, hopefully no one on the call will get a letter from the IRS on the A or B penalty. But if you do, please reach out, sooner rather than later, and we can work to kind of see, what the problem was. Is there something we could fix? And then just kind of how to best position that, in our response, to the IRS. Okay. All right. So our next few slides, we're going to look at transparency and coverage and the ever-changing compliance requirements that have come along with that. And the first one we'll talk about is machine readable files. And the first 2 machine readable files, this dates back to July 1st of 2022, right? And we have the in-network file and the out-of-network file. The in-network file provides data on negotiated rates with in-network providers, while the out-of-network file contains the amounts of the allowed amount paid and billed charges from out-of-network providers within a 90-day period. So these files have been effective since July of 22. However, the transparency and coverage requirement did call for a third machine readable file. However, implementation of that third file has been delayed. And that third file is a prescription drug and RX rate file. And the reason why the implementation and effective date of this prescription drug rate file was delayed was because of the RxDC, right? That prescription drug data reporting, data collection reporting, that was implemented under the Consolidated Appropriations Act, as there was concern that there might be some potential overlap in what was being submitted in those RxDC reports and what the machine readable file data was presenting as well. And again, I'll talk more about this in later slides when we get to the RxDC reporting. But this past June was the first year that that report was due. And after that review, it was the agencies here determined that there is no meaningful conflict between what was reported in the RxDC data reports and what's being included in the machine readable file under the transparency and coverage. So what that means for us now is that the agencies are now working on an implementation timeline and developing technical guidance for developing the prescription drug rate file for the machine readable files. So nothing is set in stone yet. There's no due date, but this is definitely something that that is coming potentially, in 2024. So we want to be aware of it. And from our compliance team, we will keep, our account teams and you guys up to speed as soon as we learn more. But again, this was kind of put on hold for quite a while, but now it's back running, and with that implementation timeline and technical guidance being worked on, we are expecting some additional guidance, in early of 2024. All right, so along with the machine readable files, I do want to discuss the differences between a group health plan website and a plan sponsor website. And this clarification was issued in FAQs that CMS issued in August of 22. So if you're keeping score at home, that guidance actually came out after the implementation date, which is sometimes what we have to deal with. But these FAQs provided guidance on the differences and then different requirements depending on the type of website that you as an employer have. And again, we'll send out the PowerPoint slides after the call, so you can click on the link when you get it. It is question 22 in the FAQs, but primarily what the question asks and what the answer provides is the difference there between group health plan website and a plan sponsor website. What the group health plan website is, it's a public-facing site with information specific to your employee health plan, while a plan sponsor website is a customer-facing website that has no information about your employee health plan. So I think, again, primarily everyone on this call today, we're going to have plan sponsor websites, right? It's your business's, your organization's website with information that's customer-facing. You're not necessarily putting out your group health plan information in a public-facing form. However, if you are, and you do fall under that group health plan website, then the requirement to post those machine readable files is with you, right? If you have a group health plan website, the machine readable files need to be linked to that website. If you have a plan sponsor website, however, you can rely on, with a written agreement, you can rely on your carrier or your service provider to post those links on your behalf. However, here, answer 22 kind of continues, the key point there being that the requirement is still on the plan sponsor. So even if you do have, a written agreement or verbal agreement, whatever it's going to be, your requirement is still on the plan sponsor to post those 3 machine readable files. So that's why our guidance here is to, one, confirm that the required machine readable files are posted, and then also work on executing a written agreement that speaks to that fact, right? Because you want to be able, because that responsibility, that requirement, even if your carrier is posting them, that requirement is still on you as the plan sponsor, as the employer. So getting that written agreement that states that the carrier, the service provider is doing that on your behalf, that will kind of cover you in case of an audit, in case any questions come up. So you can see our guidance down there with the machine readable files. Next, for the transparency in coverage and the ever-changing compliance requirements, we have the self-service cost comparison tool. And here you can see what I highlighted in red. For the 2023 plan year, your comparison tool needed to include information on 500 shoppable items, services, and drugs. However, effective 1/1 of 24, that comparison tool needs to expand to include information on all covered items, services, and drugs, going from the 500 that was a list provided by CMS to now expanding to all covered items. So our guidance here is, again, after the new year, we want to be able to confirm that that comparison tool has been updated. Okay. Moving on from the transparency and coverage, we'll talk now about the Consolidated Appropriations Act and the new filings that happened in 2023 and how they are continuing annually. So the first of those filings was, and I mentioned it earlier, the prescription drug data collection, the RxDC reporting. So the first filing here was due June 1st of 2023, and it is due annually by June 1st through the HIOS, the Health Insurance Oversight System website. I do have here annually by June 1st. I think in 24, I think June 1st is a Saturday, so it would then be the June 3rd, that Monday. But again, don't wait for the last minute, right? Let's get it in well before that June 1st deadline. So the RxDC report can be completed by the insurance carrier, a TPA, a PBM, right? Any of those three can complete the report on your behalf. But again, it's important to note that the requirement is on the plan sponsor. It's on the employer to complete the report. And if for any reason, one of those three does not complete the report on your behalf, right, you'll need to go in and complete the report on your own to meet the compliance requirements. So our guidance here is, and some of you might have seen this last year, is the carriers, the reporting entities provide a survey for you to complete. Typically, they'll be sending those out at the end of Q1, the start of Q2, and they're asking for some plan information. Right? The carrier will have a lot of the information about what needs to be completed in the RxDC report, but they may not have all of the specifics of for your specific plan. So they're going to ask for you to complete a survey. Again, please complete the survey in a timely fashion. If anything does fall through, right, we're here to help. I worked with a number of you, last May timeframe on completing the report on our own. But if your carrier is reaching out saying that they'll submit it for you, just complete the survey. Our guidance is, take them up on the offer, complete the survey, provide it back to them, by the due date, and we should be good to go. But then, of course, always, because the responsibility, the requirement falls on you, we always want to confirm submission, and I would do it by early May. For anyone that might have completed the RxDC report on their own or with Relations help last year, it is a bit of a lift. Even getting access to HIOS for this type of data is a multiple step, couple day process. So that's why I'm saying here, we want to confirm submission in early May, just in case something, goes awry. We have plenty of time, to kind of jump on and we can help, so we're meeting those requirements. So the next item, again, a new filing in 2023 that will be continuing annually is the gag clause prohibition compliance attestation. Here, the initial attestation is due by December 31st of this year. So if you have not done so yet, please complete this attestation. We still have a couple weeks left. Follow up with your relation account team. We've had internal calls on completing this attestation. So if you have not done so yet, please follow up. We'll work on it, together to get it completed. This is the first year that the attestation is due. So the time frame that you're attesting to, dates back to December 27th of 2020. So that's the time frame that you have to attest to in this first attestation. Then in future attestations, right, it's due annually by 12/31. You're going to attest for the period of time from your last filing to the date of your current filing. So pretty much that last year. So again, this the compliance attestation for the gag clause, it can be completed by the insurance carrier, TPA, PBM, or other service provider. But just like the prescription drug reporting, the requirement is on the plan sponsor to complete the report. So here, our guidance, we want to always confirm that your underlying contract complies with the gag clause prohibition requirements. And we want to check that on an ongoing basis, but primarily for this reporting, we want to confirm it in early Q4. And again, you can work with your relation team, work with me. We can certainly do that to make sure that your contracts there with your carriers, with your providers, we want to confirm that they don't include a gag clause. And just real quick, a gag clause is a clause that directly or indirectly prevents the plan from accessing certain cost and quality information and providing that information to its business associates. So we want to make sure that those contracts that you have in place with your carriers, TPAs, other service providers, they're not allowed to include clauses to that effect. So again, we always want to confirm that our contracts comply with the compliance requirements. And then again, we want to confirm submission. And I think the wording here is rather important. We just had an issue come up very recently, actually. We want to confirm submission. So we had a TPA that will remain nameless, who, when we reached out, a couple months ago, making sure that they would be completing the gag clause prohibition compliance attestation on our client's behalf, they said yes. They gave us the thumbs up and said, "Oh, of course, we're going to complete it for you. We're your TPA. We'll get it in." We followed up with them, as we should, right? We want to confirm submission, and the TPA actually came back and said, "Oh no, we made a mistake. Our practices have changed. Our policies have changed. We're not doing it anymore for you. It's going to be on your own." And our client would have never known, if we had not completed that follow up to actual confirm submission. So again, we don't want to just make sure they're going to do it, right? We always want to confirm submission. Even on the last slide there too, with the RxDC data reporting, right? That last bit of guidance is always to confirm that that submission was completed appropriately. And again, we can help you with that. All right. So the last item that we'll talk about here from the Consolidated Appropriations Act is the student loan repayments. And I'm not going to read through the slide, but you can kind of see the highlights. It extends through the 2025 plan year. So it ends on January 1st of 26. The student loan repayment was increased to $5,250 per year. And that's in total, right, for tuition, fees, textbooks, and loan repayments combined. So the CAA there extending the pre-tax benefits for student loan repayments. Next, we do have some upcoming changes to Medicare Part D. And these changes occurred through the Inflation Reduction Act of 2022. So we are going to see changes in 2024. And those changes there, you can see that they remove the 5% coinsurance in the catastrophic coverage category, which is the fourth and final stage of Medicare Part D coverage based on out-of-pocket spending. And you can see there it did, the change in 24 is also adding the benefit that Part D plans will pay 20% of total drug cost in that catastrophic coverage category. And then we also have changes that are taking effect in 2025. I'm not going to read through all of them. The things I do want to point out, though, is the coverage gap phase. What that is, it's the time between when an individual has reached their initial coverage limit, but before they reach the catastrophic coverage phase. So they're removing in 25 that gap phase that will be removed. And then some of the percentages there, you can see in the third bullet under 2025, the amounts there are decreasing to 20% and brand name drugs to 40%. Currently, those are both at 80%, so a pretty significant drop down there in percentage. So why are these changes in Medicare Part D plans important for us on this call? And the reason is for our creditable coverage, right? So Medicare Part D on an employer side, we need to confirm that our prescription drug coverage is creditable. And you can see it there on the screen, but another way of putting it is that drug coverage is credible if the plan pays as much towards prescription drugs, as a Medicare drug plan would. And there are two reporting requirements for Medicare Part D that's on the employer. The first, we have the annual CMS disclosure, which is due within 60 days after the beginning of the plan year. And again, with 2024 being a leap year, for calendar year plans, the CMS disclosure is going to be due by March 1st. And then annually, we have the Part D creditable coverage notice, which needs to be provided to impacted employees. And that's due by October 15th, which is the day before the Medicare Part D annual enrollment period. So again, the Medicare Part D changes impacting our creditable coverage and those disclosure requirements. All right. Now, on the next few slides, I'd like to talk about mental health parity and Addiction Equity Act, the Consolidated Appropriations Act, NQTLs, excuse me, and the Department of Labor. So a lot of information here on these next few slides. So to start off with, we have the Mental Health Parity and Addiction Equity Act, which applies to fully insured plans, both large and small group, and then self-insured plans that are large group only, right? 51 and above. So these are the groups that the Mental Health Parity and Addiction Equity Act apply to. And the requirement here is that if your plan covers medical surgical benefits and mental health or substance use disorder benefits, so it covers both, there needs to be parity in those plans, right? The benefits must be comparable, and that needs to be achieved at both the quantitative and non-quantitative level. So quantitative is really numbers based, right? It's cost sharing percentages, the number of visits for a service. It's something that you can look at a piece of paper and realize, okay, this says 4, this says 7. These are not comparable, right? It's numbers based. It's going to jump off the page again. The non-quantitative treatment limits, though, this is a little more tricky. So here, the NQTLs are non-number based. I like to call them more behind the scenes work. So what's the process for prior authorization, right? Are you treating your medical surgical prior auth differently from your prior auth for mental health, right? Procedures for concurrent reviews for in and out of network, are those being handled in the same way? Are the standards for a provider participating in the network, are those the same? So again, it's a little bit more behind the scenes, but those need to be comparable as well between medical surgical and mental health substance use disorder benefits. Now, what we get to here is the Consolidated Appropriations Act, which put in a requirement, because that Addiction Equity Act dates back a number of years, right? So that's been in place for a while. But what the Consolidated Appropriations Act did was now it makes a requirement that plans complete and document an analysis of the design and application of NQTLs. And additionally, what the CAA did was that it also put that enforcement requirement on with the Department of Labor. And what the Department of Labor is now doing on all plan audits, anytime they conduct a plan audit, they are now asking for that NQTL analysis. So really, it's important. It's a top button, top plate issue here for the DOL is this NQTL analysis. So who's the responsible party, right? Always important. So if you're a fully insured plan, the responsible you share responsibility with your insurance carrier. However, the carrier is obligated to perform that NQTL comparative analysis. But for self-insured plans, it's going to be the employer, the plan sponsor, who's responsible for completing that analysis. So the next, I'm sure everyone's asking, Matt, what happens if we don't complete the NQTL comparative analysis? So as I mentioned, the DOL, they're asking for this on all of their plan audits now. They're going to require you to provide a detailed analysis, typically within 10 to 14 days. And these are the penalties, right? They can impose as high as $110 per participant per day that the analysis is not completed. They could require retroactive claims adjustments, right? If they do find that there is, non-parity in some of those plan designs. And then the third bullet here, right, they do have to provide a list, an annual report to Congress annually, detailing, which plans were identified as being non-compliant, right? I think particularly the time of year, we want to just avoid all naughty lists. So we definitely, don't want to get on the NQTL list down there with the DOL and HHS. So next we have what happens if a plan fails, right? That was, hey, what happens if we don't test? Here, what happens if a plan fails its NQTL analysis? And I have fails in quotes just you really don't fail, right? It's an internal test, right? You're going to complete that analysis, and I'll actually talk about that in an upcoming slide about our guidance on how to complete that. But right, you really don't fail. So if there is a discrepancy, if something is flagged during the testing, the DOL has indicated that plans should swiftly address any identified deficiencies and then make a good faith effort to remedy any areas of concern. So again, this is more on the internal side, right? As long as we're completing the analysis, making the updates, right? Come a DOL audit, they're going to be happy with those results. All right. Next question, right? Is a NQTL comparative analysis a yearly requirement? Not necessarily. The requirement is that plans maintain a current analysis, right? So if nothing changed in your plan year over year, you probably don't need to complete this yearly. However, changes, particularly major changes, right? It may be something that we want to, re-engage on. But again, it's a current analysis. So here, our guidance, and this goes for both fully and self-insured plans. You should confirm with the carrier, one, that your medical plan complies with the requirements of the Mental Health Parity and Addiction Equity Act, right? I think that's like the first and foremost, like make sure that your plan, it's meeting those parity comparable requirements. Second, and again, this goes for self-insured as well, right? I think we should be starting with reaching out to the carriers and asking the carriers if they completed and documented an analysis of the design and application of the NQTLs. And if they say yes, also follow up with, will they be able to provide that required documentation upon request? We had a self-insured plan, right? And typically a few slides ago, right, we talked about that the analysis for self-insured was on the, plan sponsors requirement. However, we had a self-insured plan. We followed up with the carrier, and they said, yes, we complete the analysis for you. We can give it to you on request. So we covered our bases there. The thing that the carrier did point out, though, was that the group did use their standard plan design. There was no deviation there, which we confirmed. So we ended up being in a really good place just by asking that question to the carrier, even though the plan was self-insured. So that's why we have that guidance there. And then the additional piece of guidance, and it's similar to the guidance that we provided before, we always want to try to get this as an executed written agreement, that the plan will, one, that it does comply with the underlying requirements for mental health parity, but then two, that the plan will, upon request, not only complete the analysis, but also provide it as well. And again, please, right, I talked about it at the start, right, this is kind of like our jumping off point for these compliance conversations, right? If you have questions or you want to go into more detail with NQTLs, it's a complicated issue. Please feel free, connect with your relation account team. Let them know you want to get on a call with me to discuss, what you have in place now, and we can certainly, walk you through this in a little more detail, I think, on a one-on-one setting. All right, 2 more slides. All right, so here we have compliance overviews with state disability insurance laws, and then a state law overview for paid family and medical leave. And to be honest, these issues, they are current, they are changing, right? They are very fluid, right? With states revising or implementing new family medical leave, right? Revising their disability insurance laws. We work on keeping everyone updated on these changing compliance requirements, right, through our compliance newsletters, through compliance alerts. So please keep reading those. I'll assume everyone reads our compliance newsletters. Thank you for reading those. They get sent out, I think, every other Tuesday. We try to send those out to you. So please continue reading those to stay up to date on these, compliance overviews that we provide. And actually, earlier this year on one of these quarterly compliance webinars, we had one of our partners join us that works specifically in the family and medical leave space, both federally with the FMLA and at the state level. And I thought our partners there did a wonderful job of kind of talking about, some different requirements in the states, what was being proposed, where they kind of saw, paid family and medical leave going at the state level. So what I will do with these 2 documents, when we do send out the recording, the PowerPoint slides, I'll make sure to attach these two supporting documents so you can read them. They have some really good information on them. And our strategy, again, for 2024 is to have a webinar specifically on state disability and paid family medical leave. So certainly this is a good maybe appetizer, and definitely more information to come on these two issues. All right, and the last slide here, I'm not going to read through all the numbers. When we send out the slide, feel free. We have the benefit plan limits. So we have different plan types there on the left, the 2024 limit there in the middle, and I thought it'd be good to just put in the 2023 limit as well, just so you can compare, what's in place for 23 and where it's moving to 2024. All right, and with that, we come to our questions. And again, I know I said it a few times, but we're here to help. And again, thank you everyone for joining our compliance webinar today. I really appreciate taking time out of your busy schedules. I know it's a tough time of year with work and holiday season. So again, thank you so much for again working on strengthening that relationship with compliance. So Kat, do we have any questions?
Matt, no questions came into the chat box.
Okay.
I was going to see if I could try to unmute folks or give them a couple of seconds to enter a question in the chat. Let's see.
And again, feel free if a question pops into your mind, after the webinar, tomorrow, whenever, reach out to your account team. They'll contact me and we'll get that question answered. So if, feel free to, digest this. And if there's any questions come up, like I said, this is a starting point. Really happy to continue, our compliance conversations moving forward with everyone.
Yeah, no questions came in so far.
Okay. All right. I think we can end it then. Again, everyone, thank you so much for joining today. Have a wonderful rest of the day, and I look forward to working with everyone as we move into the new year. Thank you so much.